Ahmed Raza, and he would be talking about internal hernias after bariatric surgery. Dr. Javed Ahmed. All the participants, please come back and join the session. You can bring that cup of tea along with you.
So, are we going to start? Is everyone coming back? Rizwan? So, Dr. Tanveer Razi is going to do the presentation on my behalf. I've learned to be a manager. Right, so let's start. I think we'll have to work through lunch. So, presentations are on here. Hanif Sahab, how much time do I have?
So you have 15 minutes.
Okay.
13 minutes.
13 minutes plus 3.
10 plus 3.
Okay, 10 plus 3. Okay, so I'm going to talk 5 minutes, and then I'm going to take you through a video, a case that I did on Wednesday. So I didn't get time to edit it. So I'll forward the video and show you how we deal with it. So briefly, we'll understand for the PGs especially. People sitting on the front, they understand the anatomy of Roux-en-Y gastric bypass and where the defects are. But for the people sitting on the back, it's important to understand that. And then we'll go through what are the symptoms, how we recognize it, and what we do about it. So, just to give you an idea, almost 23% of the operations done in US are Roux-en-Y, and vast majority in this country, one or other type of gastric bypass. So the anatomy in reference to Roux-en-Y gastric bypass, the do we have a pointer? Yeah. Okay, I've got it. The presentation is gone. Yes. Presentation गायब हो गई है. लगी हुई. Slideshow में थी वो. Okay. So, for the residents, this is the gastric pouch, and the part of the jejunum that is attached and comes down is the roux limb or the alimentary limb. The duodenum, which is in green, comes and joins, the jejunum joins here. This is the JJ anastomosis. So, this is just the definition of these limbs, and the bowel that is small bowel further on is the common channel where the digestive juices and the food mix. So that's the basics of it. So these are our, so internal hernia, like the definition of any hernia, is a protrusion through a naturally occurring or surgically created defect but has no bump on the skin. So that's an internal hernia. The common factors: rapid weight loss, loss of fat inside. The stitches that you put in an obese patient, they can become loose, or they can, and if by mistake you're not using non-absorbable sutures, you have to have permanent sutures to close all those defects. It can herniate and come out back again, or if it's a big hernia, it can herniate to a larger degree and twist around itself. That can result in obstruction, or in rare cases, ischemia. So the defects, the first defect here is where you do the jejunal anastomosis, and that's the JJ defect here. The second is where you take the jejunum up to join with the stomach, you cross the transverse colon. This is anticolic. The mesentery of the transverse colon and the mesentery of the small bowel, they join like this, and this is where the bowel comes through. So that's the Peterson or pseudo-Peterson. If you do a retrocolic approach, then you create a defect in the mesentery of the transverse colon, and you create this additional hernial defect. This is actually called the true Peterson. This one is pseudo-Peterson if you're trying to be too accurate about it. So reported incidence roughly 0.2 to 8.6, depending on who's following up for how long, and if your cases come back to you. It is one of the main reasons for bowel obstruction after gastric bypass. I did my first 500 cases with this configuration because Calvin Higa did it like that. And I then had 1 or 2 incidences of hernia from here, so I changed to this configuration. Now I do anticolic. So retrocolic has higher incidence. The typical timing, 6 to 24 months. So when they lose weight in first 12 to 18 months, and it can be a vague abdominal pain off and on, or it can be a sudden acute abdomen presentation. We get patients in our clinics with intermittent abdominal pain. What you do an ultrasound scan to rule out gallstone disease. If there are no gallstones, hiatus hernia, and then you do an upper GI. It's very rare to find internal hernia in an elective patient in the clinic. Usually you catch it, but you have to be suspicious about an internal hernia when you can't explain that pain on something else. So silent or atypical, you do labs, x-ray, everything is normal. In pregnancy, post-gastric bypass, the pregnant uterus pushes everything up, confuses the hell out of you, and that's the most difficult because your radiological options and your surgical options are very limited at that time. The case that I did last week had a gastric bypass done 20 years ago at an outside facility. And he presented to my clinic. I'll go through that story in a minute. And in between, the patients would have no symptoms. So this is something that you need to be constantly out to look for in any gastric bypass patient. The emergency departments who normally don't look after bariatric patients can very easily miss it. In your hospitals, please go and educate your emergency medical team about bariatric surgery complications and how to deal with them. Ideally flow charts, and ideally one of you should be available 24 hours for at least a phone call or for guidance. So history is very important. Labs, yes, if lactate is high in an acute, you become more suspicious. Pain out of proportion indicates that it's probably ischemic now, it's twisted to a degree, even if you don't find signs, but very bad pain, suspect it's internal hernia. Contrast CT is the most reliable. This is the normal configuration of vessels and bowel around it, and if it's twisted, is the swirl sign. Not always present, but if it is present, it's very useful. If you do a CT, you can also see the superior mesenteric vein engorgement as well because of the obstruction. If you see small bowel in the left upper quadrant on a CT, a lot of small bowel, be very suspicious. Even if there's no swell sign, write history, and a lot of bowel in the left upper quadrant, consider it to be an internal hernia until you can prove otherwise. So a negative CT, this is the message I really want to, you don't want to say, okay, I did everything, we investigated, and then there was no internal hernia. If a patient comes to you as an emergency, don't let the patient sleep in the hospital without an operation. That is one message I really want to give. A negative laparoscopy in a post-bariatric patient who has lost weight is not a problem. Not doing a laparoscopy and losing the bowel is negligence. So for trainees especially, please, 2 messages for post-bariatric surgery patients. 1, tachycardia immediately after surgery, there is a problem, don't ignore it. 2nd, internal hernia suspicion, do not let the patient sleep in the hospital overnight and deal with it in the morning. You have to do it middle of the night. If you're going to do bariatric surgery in your hospital, you have to talk to everyone that you will need to take the patient to OR at odd times, even if it means negative. So this is the sort of working algorithm. I'm aware that I'm short of time, so these are the differential diagnoses, but none of these gives you an excuse not to suspect it to be an internal hernia. So laparoscopic management, I'll walk through on the video, and every mesenteric defect should be closed in Roux-en-Y gastric bypass. This is not a controversial topic anymore. Okay? Not a controversial topic. Every internal hernia defect needs to be closed in Roux-en-Y. We now strongly suggest that all operations where you take small bowel above in front of the transverse colon, you should close, but there's not enough evidence for me to, I would do it if I do it. This is the literature review, and you're welcome to my slides. I'll leave it. And so always history, suspect internal hernia and unexplained abdominal pain, atypical symptoms. I just want to talk about Midland Doctors. This is the charity hospital that I've been involved with for the last 20 years. This is an 80-bedded hospital, completely free. We've constructed it and we are running it. We have a CT scanner now, angio machine. We do all sorts of laparoscopic surgery, and we run laparoscopic courses. This is completely free to the patients, and we have treated more than 700,000 patients so far in this, including surgery, all radiology. This is where I live in Abu Dhabi. I welcome you to come to UAE. And now I just want to quickly go to that video. How much time I've got left?
2 minutes, sir.
Okay. So let's see if I can just show the salient parts. Access in post-bariatric weight loss abdomen can be a challenge. Abdominal wall is loose. Your optical port entry can be a huge challenge. So anyway, we get in. Okay, let me go back a little bit just to... So I was talking to Dr. Carlos about this, that for the last 10 years I've been telling people, go to the cecum and make your way up. And when we've lost the feed. So it's very tempting when you go and you see bowel sitting there, okay, let's start pulling and pulling. And despite banging about it for years, I succumbed to the temptation in this case. I said, okay, maybe it's an easy one and I'll pull it out. And after 5 minutes, I stopped and said, what are you doing? Go back to tell people to do what you tell people to do, not you think is you should do. So after spending, I'm sorry, we are having technical problems. So what I did in this, I then went back to the other side of the patient. I normally operate from the right. I found the cecum and I started working my way back up until I felt that I could not. So I put a stitch and then I went back to the patient's left, to the patient's right, and then I worked my way. So this is when I'm trying to see, okay, maybe I can pull this out. I'm trying to be very gentle and not cause trauma. Let me find the bit where I go to the cecum. And this is where I thought the defect was. So what you have here, so this is the mesenteric defect that was never closed. So this is a massive defect and the entire bowel had gone around. So this is now, I decided, okay, I can't make sense of it. I go back to the cecum. This is the ileocecal valve. And we're working our way up. Once I've done maybe 100 or more, I put a stitch so that I can recognize the direction. I go back on the other side and then I keep going proximally. And now it's coming out without trauma because I'm not trying to force it through. And you can begin to see where it was congested. And here there's a long blind end on the JJ, and that was very confusing for me to orientate where the defect is. We can ask questions while I'm doing it, so I don't want to sort of take longer. And then we realized, okay, so this is the defect here. So I decided to resect that blind end to orientate better. So finally, this is the mesenteric defect here. And this was just a pseudo impression of that. This is the blind end. So once we resect that, it is clear that I have to close this. And you can see probably inferior mesenteric vein, you had glimpses of that there. So this was the and while I was waiting for the stapler, I looked at the Peterson and there was a defect in the Peterson, so I'm just closing the Peterson defect in a purse string with a non-absorbable V-lock. So what I do is I start closer to the small bowel lumen, work my way down, and then work my way up. So the two mesenteries meet in a V. So you work your way down and then up. I also put the needle through the loop so that when you take the stitch, you don't need to do it inside. It just slides on top of your needle holder. So there's benefit in watching an unedited video because you see all the struggles as well. And then you need to make sure that you check, make sure you haven't left a small defect here. And I take a second stitch just to lock it, just a small one. And then last minute of this video and my talk. So we now divide the mesentery, divide the bowel. And then we close this defect. Again, going down and coming up, same as I do all my mesenteric closures. Okay, so that's the end of my talk. So I just want to say that if any type of bypass comes to your service from wherever, whosoever has done it, top of your suspicion should be internal hernia unless you can prove it otherwise. Secondly, please do not let your patient stay in the hospital without an operation. A lot of time they may come late, but if they have come, then it's your responsibility. In Cleveland, we have seen patients who lost all their small bowel, and we had to get them to a small bowel transplant in Cleveland, Ohio. So it's a very, very serious, and that was a young 29-year-old girl who had that. So once you have seen that how it can destroy someone's life, the reason why I want to bring these horror stories is for you to realize how important it is, and overdoing a laparoscopy, especially if they've lost weight, they're low risk now. So thank you very much, and I'll stop here now.
Thank you.